Hi everybody, Thatcher came in from Taste Media Group coming to you on LinkedIn Live today. We are joined by Dr. Michael Awad, a board certified gynecologist and obstetrician in private practice here in Chicago. Dr. Mike, did I get that all right?
You did get it all right, Thatcher.
Okay, that's a mouthful here. We don't have the luxuries of a teleprompter, so I'm trying to channel some of my old reporting skills here.
You're all
But
good.
we really appreciate your time. I know it's a very somewhat chaotic time, if you would, for the medical profession. But as an OBGYN, I mean, it's business as usual for you, right?
Thatcher, it is. Part of what we do is just gynecology, but we do obstetrics. And in obstetrics, the show must go on. We cannot stop our care for our patients who are pregnant. And we have to continue delivering that valuable care to them, no matter what the conditions.
And so while you're delivering that care, I mean, there must be just a million thoughts going through your head as a practicing physician who's out there servicing the public, just not knowing as well because you're not, you can't really test yourself, correct?
That's correct. So right now, the Illinois Department of Public Health doesn't have any recommendations for testing asymptomatic clinicians. We are continuing delivering the best care that we can during these times. We're not stopping seeing our pregnant patients. That is not the current recommendation. We are trying to screen as many patients as possible to see if anyone is ill or is showing symptoms. But as far as the care that we provide, we have not stopped seeing patients. As pregnancy does, there's a lot of moving parts in pregnancy, and we cannot afford to take time away from our patients.
And so looking at a little bit of a bigger picture here from the medical profession, Michael, what has been the overall sentiment within just the other doctors and practicing physicians that because the elective surgeries have all been put on hold?
Thatcher, that's been very, very difficult on all of us as a medical community, as well as my colleagues in private practice. We depend on our clinics to bring in and see our patients, to provide services for the patients, and ultimately provide jobs for the staff that we employ. Taking away and having been put down to a very skeleton clinic has been very challenging because we as physicians took on this job to help people, and having our hands tied has been extremely, extremely challenging. We've been trying to bridge the gap with telemedicine, seeing patients via telemedicine links. But as physicians, it's been one of the biggest challenges is being rendered helpless in seeing patients for elective reasons.
And that's one of the main points is it might be quote unquote elective surgery, but that might be a hip replacement, a shoulder replacement, where the patients are still in pain and they don't really know like when this will come back online.
Absolutely. I mean, we have had patients in our clinic cancel hysterectomies that are in terrible pain and have bleeding issues. But the current recommendation now is that if it's not going to cost you life or limb, within 30 days, we are instructed to be put on hold. And I do believe that is the right course of action at this time.
And in terms of the COVID-19 virus itself, when did it first become on your radar? Because you're also a teacher and professor as well. I mean, were you kind of reading about this earlier on, or when did it just kind of come to fruition and come across your plate?
So it came across my plate in January. We had been reading about this virus, coronavirus, and a coronavirus is a upper respiratory tract virus. The family of coronaviruses have been well known for years, but this particular COVID-19 virus showed up in about mid-January and it showed to have a devastating effect on the population in Wuhan. That was then, publicized by the news, and we saw the spread of it. And the problem with the virus, Thatcher, is that this virus is spread so easily. There's a concept called the R naught. The R naught of a virus is how contagious it is, and this is 2, maybe 3 times more contagious than the seasonal flu that we see every year.
And in terms of the information that was coming out of China originally, I have really no idea. You know, you hear things all across the board, but from a practicing physician slash academics point of view, you know, is there a medical sector of China that was kind of bringing this to the forefront where sometimes you can't always, you know, assume what the government's telling you is true?
So there are all sorts of conspiracy theories as far as what has been given to us as a medical community from China. And to be honest, we can only go on what we have and the data that we have. And the data that we have shows that about 80,000 people, 80 to 90,000 people were infected, and now they have flattened the curve and are seeing many less patients being infected every day. That is something that we hope to, if these numbers are reported to be correct, those are numbers that we hope to see here, as we are obviously very far behind them, or about a month and a half behind them. But from the numbers that we have seen in China, we hope they are correct. We hope that they have flattened the curve, and we hope that we are along the same trajectory.
And so when we see the numbers here in the States, it's just unfortunate. I mean, the way it's reported, it's like the amount of people who have it and the amount of people that have died from the virus. But the amount of people who have it, those are the people that have been diagnosed. Those aren't the people that currently have it, if assuming it's a 2-week process. Am I tracking correctly there?
So you are correct. So the number of people who have had it, that's the people who have tested positive. That's assuming we have the tests that are necessary to diagnose these patients. But it doesn't represent the number of people that actually have it, because there will be a sector of the population that will show mild to absolutely no symptoms, but are still contagious and can infect others. Those others that are infected are susceptible to becoming very ill. So we don't have a good 1-to-1 ratio on you're old, you're going to get very sick, you're young, you're going to be fine. We don't have that. We have guidelines and we have generalities that, yes, people who are older with underlying health conditions generally tend to do worse, and we risk stratify those into high-risk patients. Unfortunately, there are going to be some younger patients with underlying medical conditions that we don't know about, that we find out about only after they get sick. We have people with different immune responses. A lot of what causes the pathology of this virus is the immune response, and causing a lot of fluid to build up in the lungs, and something called ARDS. And ARDS is a very debilitating inflammatory condition of the lungs that basically restrict your breathing. And when you have ARDS, you need to be placed on a ventilator to allow air to go into the lungs that are inflamed. There may not be enough ventilators if enough people get sick at the exact same time, which is why social distancing is so important, to buy us time. And this is a game of time. In time, there will be treatments to help better care for people who are sick. In time, there will be the development of a vaccine. In time, we will have the necessary testing to do to be able to test people that are just merely exposed and not have tested positive. We just need to buy time. And what the emphasis has been on by the government and by the medical community is give us this time. Stay home, try to flatten the curve, do not expose try to limit the number of people that are exposed as much as humanly possible, to buy us this time so that we can get everything that we need against the war that we are about to fight. You don't want to go to war without the necessary tools and weapons that you need to fight this war. And unfortunately, we need time to get those weapons.
A friend asked me today too, they had pneumonia in the past, and when this conversation kind of went from, oh, it's a cough to it's pneumonia, I mean, pneumonia is a whole nother level. But my question is, are people that have had pneumonia in the past as susceptible to this because they might have antibodies to help them as well?
So pneumonia is not necessarily the cause, it's usually the effect. Pneumonia is a consolidation within a part of the lung. This COVID-19 virus can cause a pneumonia as well. And that pneumonia is a consolidation in part of the lung that is infected either by a virus or a bacteria. So having a pneumonia in general does not provide you the antibodies necessary to fight COVID-19, because COVID-19 is a discrete entity altogether. Interestingly enough, though, there have been new trials that are just being started, giving patients who have been infected and since recovered from COVID-19 and giving their antibodies through plasma transfusions to patients who are severely sick. There has been some promising data, some things that are looking up and up, but we don't have the information necessary now to be able to provide this as a standard of care or treatment.
And does the pure amount of people that are currently infected from just a medical research standpoint really help and expedite the process for trying to find a vaccine that would be available for general consumption? Or is that like not really as relevant, just the amount of people that have it? I mean, it's just like you said, it's more of a time-based thing.
So finding, there's been a lot about this, Thatcher. There's just been so much about the vaccine and the treatment with the malaria drug Plaquenil. Here's the issue with that, and the hang up with that. We don't know. We have anecdotal tales. Let me start first by saying the vaccine. All right, according to the vaccine, we started a vaccine trial earlier this month, and we're about 2 weeks in, and that's a phase 1 trial. So we have to establish first safety, right? Because our job as a medical community first is do no harm, right? We don't want to hurt anybody. We don't want to make them worse than they were when they came in and got treatment from us. So we have to establish a safety profile. And a safety profile has to be established based on dosage, based on number of patients the type of patients we hope to treat to be able to get a vaccine. So we're in very early phases. I do not expect a vaccine to be developed within this year. It's very, very unlikely. As far as treatment profiles and the number of people treated, there's been this new data that has been very promising using Plaquenil, which is an old malaria drug, as well as azithromycin. And what this does is basically prevent the virus from entering the cell. The cell that's affected is a very specific type of cell in the lung. It's called the type 2 pneumocyte, which helps produce things that help keep the lungs inflated, called a surfactant. So we're trying to use this type of drug, Plaquenil, to help decrease the rate of the virus infecting the cell. But we're so early in being able to tell whether this is an effective treatment for the masses. We don't know enough right now to give guidance, but we're trying everything we have right now, and this seems to be a step in the right direction.
Yeah, we're so thankful for all the medical professionals out there who are really on the front lines of this. Any other parting words here for just moving forward here for just the general knowledge for people that are going to be watching this, Dr. Mike?
Yeah, so my best advice to everybody right now is to listen to the advice given to us by the powers that be. I mean, there are a lot of people that are modeling this data, a lot of people that are looking at your individual actions and magnifying them by tens of thousands to millions. So each individual action is multiplied by so many other actions and has so many ripple effects that you don't see what you're doing by staying home, by keeping your social distancing, but it's having an effect. And we're starting to get those numbers rolled in. You're not going to see the flattening of the curve quite yet, but what you do will ripple into 2, 3, 4 weeks from now when we're going to see this flattening of the curve because of what you're doing. So don't think by doing nothing, you're doing nothing. You're actually doing everything. So it's a paradox in saying sit at home and do nothing. You're really helping us out, but you really, really are. Because when patients come rushing through the emergency room, when patients come rushing through our doors, we are not going to be able to treat everybody, and that's the reality. We don't have enough staff. We don't have enough ventilators. We don't have enough protective equipment. We don't have everything that we need to keep ourselves safe, because we want to be there for everybody that comes in that's ill and treat them. We don't have enough to keep each other safe from other patients that are coming in as well. So stay home and listen to what your healthcare community is telling you, as well as the government. And the last but not least, I just want to urge everybody to be positive, okay? Whether you're a business owner, whether you work in a factory, whether you are in medicine, or no matter what you do, just try and remain positive. Don't act too quick. Don't rush to make decisions. Keep your staff on board. Keep your employees with you. Keep everybody happy. I know this is a scary time and the fear of the unknown, but we're going to get over this. And we have good data to support that we have an ability to do this if we just do the right thing. But overreacting can prove to be more detrimental to all of us in the future.
Excellent advice. We really appreciate your time. We appreciate everybody watching, and hopefully this will provide some insight moving forward. Thanks again, Dr. Mike, for your time.
Thanks, Thatcher. Good being with you.